Welcome to Tracheostomy Fundamentals, an in-service from Northwest Respiratory Services. My name is Darren Phillips. I've been a respiratory therapist with Northwest Respiratory Services for 15 years. Today we're going to learn about reasons for a tracheostomy, types and parts of a trach tube, inflating, deflating the cuff and plugging the tracheostomy tube, humidification and suction, and tracheostomy care. Some definitions of a tracheotomy, which is actually the procedure when a doctor makes an opening in the front of the neck. It's a direct incision into the trachea or the windpipe. If you reach up and find your Adam's apple, go down just below, you'll feel a flat spot of cartilage. This is called the cricothyroid membrane, and this is the direct spot where they make the incision. It is below the vocal cords, so any person that has a tracheotomy and gets a tracheostomy tube inserted cannot vocalize due to that. The tracheostomy itself creates a patent airway. It's the actual opening in the front of the neck. It's also called the stoma. Some indications for a tracheostomy is to bypass an upper airway obstruction, tumors of the head and neck, acute inflammation of the neck, and injuries. It allows for artificial ventilation after an extended period of time on the ventilator and for long-term respiratory support. In the beginning of an acute injury, a patient will normally get intubated through the nose or the mouth. Once they have had this in for approximately a week and cannot get weaned, they will do the tracheostomy. It provides for better infection control and also for better oral cares. So parts of the tracheostomy tube, and we'll review more of these later on down in the in-service, but we've got the faceplate, the outer cannula, the shaft, the fenestration, and not all trach tubes have a fenestration. We've got the cuff, the pilot balloon, and the inner cannula. And a little more on parts of the tracheostomy tube. The outer cannula, this is the tube that is placed in the stoma. This creates a patent airway. The inner cannula is a removable patent airway. It fits inside the outer cannula and it acts like a liner. So at any point in time, if we have secretions that plug up that inner cannula, we can remove it, put a new one in, and we have a patent airway once again. The inner cannula can be removed for cleaning or changing, and nowadays most patients have disposable inner cannulas. They're trying to get away from the non-disposable inner cannulas, which have to be cleaned. So again, more parts of the tracheostomy tube. You have the obturator. It's a plastic guide with a smooth, rounded tip. This is our obturator, and this should be placed in a sealed, sterile bag above the patient's bed in case of emergencies. It's used when putting the trach into the stoma. If we look at the edges of the trach tube, they are kind of rough. Some of our trach tubes are harder plastics, which can, if it's inserted without the obturator, we can cause mucosal damage. And it's used for routine trach changes. Accidental decannulation, we need to have the obturator always handy so we can get that tube back in place. The cuff. This is a balloon surrounding the outer cannula near the base of the tube. Once inflated, it seals off the upper airway to create a safe patent airway so nothing can get aspirated down into the lungs. Not all cuffs are filled with air, and we'll talk a little more about this later as we go over the different types of trach tubes. There are some that incorporate sterile water, there are some that are foam, and some that have air. So we need to know exactly which tube we are using so we don't put the wrong product in the cuff. And not all trach tubes have cuffs. The pilot line. This is a small lumen tube connecting the cuff directly to the valved pilot balloon. It runs along the side or the back of the trach tube and the outer cannula. The pilot balloon provides direct, independent connection to the trach cuff via the pilot port. This is our pilot balloon. This is the cuff. We get a direct reflection of the pressure within the cuff by squeezing on the pilot balloon. Using a syringe attached to the pilot balloon valve, the cuff is inflated or deflated. An inflated pilot balloon indicates an inflated cuff. And then we have the face plate. This is the plate around the opening of the outer cannula against the neck. It's usually held in place by trach ties. The markings on the face plate are extremely important. This tells us exactly the size and the diameter of the tube that's in place. So whenever you're reordering supplies, you want to make sure we match up the markings with the reordered tube. Once again, we've got more types of trach tubes. Here we have the metal tube, or the Jackson. The Jackson tube started many years ago. It was the standard in tubes. Then as technology progressed, we went to plastic tubes, and now the metal Jackson is kind of making its comeback again. It consists of an outer cannula, an inner cannula, and an obturator. It's used for patients with a permanent tracheostomy. There is no cuff. The advantages to the Jackson is that it can be sterilized for reuse. The disadvantages: it's expensive, it's rigid, it's extremely heavy, and it needs a special adapter to be used with a respirator or a resuscitation bag. And it does not have a cuff. So there is a chance of aspiration. The silicone tubes, or the Bivona, consist of an outer cannula, an obturator. Based on design, may have an inner cannula and or a cuff. The cuff can be filled with sterile water or saline. It is extremely important, if you're using a Bivona cuff, that you read the package instructions to know if it's an air-filled cuff or if it's a saline-filled cuff. If you put air in a saline-filled cuff, the air will diffuse out of the cuff and the cuff will go flat. The advantages of the Bivona: soft and pliable, and the material has a property of reduced adherence of mucus and bacteria. The disadvantages: generally not equipped with an inner cannula option, and there is no fenestration option. And we'll discuss fenestration here in just a moment. The plastic tube, the Shiley. The Shiley is kind of the standard tube, I should say the most common tube, when we have somebody that has a tracheostomy. It consists of an outer cannula, an inner cannula, obturator, can be cuffed or cuffless. The advantage of the Shiley: there's a vast array of designs and features. It's a rigid tube, can make placement easier, allows a fenestration option, and the material is thermosensitive, which means that it will actually soften once it gets inside the patient's trachea. The disadvantages: it is rigid, and the nature of the material may be uncomfortable and is more prone to adherence of mucus and bacteria. What we sometimes see, that if a patient has a Shiley in and they can't tolerate it due to the rigidity, we will move up to the Bivona. And a fenestrated tube. Once again, the Shiley is our only fenestrated tube. It's a hole in the curved part of the trach tube. And what this allows for, when we deflate the cuff, it allows more air to go up through the vocal cords, so when we're in the process of weaning a patient, they can phonate better. The inner cannulas can also be fenestrated and or non-fenestrated. So if we need to protect that airway, we can put a non-fenestrated inner cannula in. If the inner cannula is non-fenestrated, air is only able to pass around the tube with the cuff down, and vocalizing is more difficult due to increased resistance. Alright, moving on here to trach cuff management. Inflating the cuff. Air and secretions are not allowed to move to and from the upper airway at the point that the cuff is inflated against the tracheal wall. Cuff inflating is indicated in the following situations. When using mechanical ventilation, we will lose our pressure if the cuff is deflated. When the patient has a paralyzed swallowing reflex, during feedings when the patient is learning to manage liquids or solids, and as ordered by your doctor. Hazards of an overinflated cuff: tracheomalacia, erosion of the blood vessels, abnormal collapse of the tracheal walls. Submucosal circulation can be cut off if pressures of the tracheal wall are too high. When we look at the cuff, we're going to talk about the minimal occluding volume technique here in a little bit. But if we look at the package of the trach tube, it will tell you how many cc's of air the cuff can hold. That does not mean how many cc's of air you should put in the cuff. Most cuffs are about a 20 cc capacity. If we do that, that's just about to the breaking point of the cuff. So we want to make sure that we don't have too much pressure in the cuff, but just enough to make the cuff sealed in the tracheal wall. So hazards of inflating the cuff, or underinflated cuff, aspiration of the gastric contents, decreased delivery of tidal volume in ventilated patients. When we deflate the cuff, air is allowed to flow between the trach tube and the tracheal wall and thereby through the upper airway. Some indications for cuff deflation, if we want our resident to be able to talk. When using a speaking valve or a passing mirror valve, and we're going to touch on this subject a little later on in the in-service also. When the trach tube is being plugged for weaning purposes, when we are removing the trach tube, again as ordered by your doctor. Passing mirror valve attaches to the trach tube. The valve allows for patients to inhale through the trach tube and exhale through the upper airway. Used for speaking, but can also assist with trach weaning. When you're using a passing mirror valve, it is of utmost importance that we always have this cuff deflated. The passing mirror valve is a one-way valve where the patient can breathe in through the trach tube, but they cannot exhale through the trach tube. So if our cuff is inflated, they'll get one breath in, and that is it. They won't be able to exhale. So extremely important that we make sure that cuff is deflated before using the passing mirror valve. Okay, minimal leak technique ensures proper cuff inflation, prevents tracheal damage caused by an overinflated cuff, assures adequate seal, and prevents aspiration. The technique or the procedure itself to obtain a minimal leak. Number one, we want to suction the patient, trachally and orally. Very, very important. We want to withdraw all the air from the cuff, and we're going to place a stethoscope over the trachea area of the neck. Right or left side, doesn't matter. And while you're listening, slowly insert air, or water if it's a bivonum, with a syringe into the pilot balloon. Continue until no air movement is heard. Withdraw just a little bit of air till you hear the first sound of the air movement. Stop and remove the syringe. Record the amount of air or water used to inflate the cuff. This is the minimal leak. And again, this is very, very important. If our customers are on a ventilator, you may have to seal the cuff completely so you don't hear any air. Plugging of the tracheostomy tube. Trach plugging is an effort to assist with weaning a patient from the trach tube while the tube is still in place. Plugging the trach allows a patient to breathe through the upper airway only and not through the trach. This is usually for short periods of time at first. Once a patient can tolerate a minimum of 24 hours of continuous breathing with a plug, the trach tube usually can be removed. Here's a couple different styles of plug. This is a cap that goes right over the end of the trach tube. And here's an inner cannula that is also capped. Removal of the trach tube is referred to as decannulation, and once removed, the incision or the stoma will heal over. If a physician deems it necessary to keep the stoma open, we can use some form of tracheostomy button. All right, as we move on here, we've talked a lot about the tracheostomy tube, the inner cannulas, the outer cannulas. We need to discuss humidification. Since we're bypassing the upper airway when we have somebody that's trached, that's our natural humidification system. So we have to add some form of humidity to the lungs so our secretions do not dry out. A couple different types of humidification. We have the HME. These are getting more and more popular nowadays. They're classified as a heat and moisture exchanger, an artificial nose. They're a disposable product that attaches to the trach tube. It traps exhaled humidity in a treated filter medium, and it redelivers that humidity again back to the lungs when they inhale. Medium to medium high efficiency. We do have some issues. If the resident coughs, they can plug this up. So we have to be very diligent in keeping it changed. Then we move on to the large volume nebulizer system. Used with a compressor to provide aerosol, oftentimes heated if we need more and more moisture. Some considerations: ensure the patient's secretions are mobilized. Temperature should run about 35 to 37 degrees Celsius. Empty the drain bag periodically, monitor the temperature, change the circuit components weekly. Set our compressor at 20 psi. Set dial on large volume nebulizer at 40%. Here's your nebulizer setup system. This is the Easy air compressor, and here is our pressure dial. Again, we don't want this at any higher than 20. Maximum of 20, we've got a large volume nebulizer, and the way this works is it actually pulls water up through this tube, slams it up against a ball inside there due to the pressure, and creates a very, very fine aerosol or mist. We can bleed in oxygen with the U adapted if necessary. Here's our drain bag, and the resident has the trach mask on. Molecular humidifier. Once again, we're using a compressor with this type of system to provide a flow of heated, humidified air. Some considerations here: ensure the patient's secretions were once again mobilized. Temperature should also run 35 to 37 degrees. We want to empty the drain bag periodically and change our circuit components weekly. We're going to set the compressor at 20 psi, set our dial of our percent O2 lock, some of you may know that as a Venturi mask, to 40%. And here's our system. Once again, we have our compressor. We want to make sure that our pressure is no higher than 20. This is our percent O2 lock system, or the Venturi mask. This is an MR410 heater, water chamber, and we're literally forcing pressure over top of the water and giving it to our resident. Alright, so maintenance of our system, cleaning. The water chamber that you just saw in the previous slide, we want to wash that daily with mild soap and only use distilled water in this chamber. Replace that chamber monthly. The percent O2 lock, or the Venturi system, used with our molecular humidity system, you want to replace that monthly. Air compressor filters. As with concentrator filters, if this is in a long-term care facility, we want to make sure we wash them weekly. And as needed with mild soap. Let them completely air dry before placing back. It won't hurt the machine to run for short periods of time without those filters in, but it's of utmost importance that we wash those filters out, otherwise the machine can overheat. Replace any disposable products weekly and as needed. The nebulizer, the blue tubing, the water trap, the trach mask, the green O2 tubing, your O2 bleed-in adapter. This is all classified as the circuit and should be replaced on a weekly basis. One thing I want to also talk about shortly here, this yellow top nebulizer. We want to make sure when we do put water in that when we screw the bottle back onto the top, that it's not cross-threaded, and make sure that it's not cross-threaded to the compressor itself. We'll lose pressure. Ordering of replacement supplies. Number one, we can contact customer service, or you can talk to your respiratory therapist. Place your order for supplies to last at least a month. I always tell my customers, please order your supplies when you have one change out left. Any troubleshooting problems here, we want to keep water drained from the tubing. Once again, keep your compressor filter clean so the machine does not overheat. Ensure connections are straight and snug. Ensure that all components of the nebulizer are changed as scheduled, and call Northwest Respiratory Services if there's any problems. Once again, supply reordering here. Number one, this would be the compressor. The 5705 heater, which is a heater that plugs in directly between here, or a sleeve that's not shown here. The 1770 large volume nebulizer. This is our yellow top nebulizer, blue corrugated tubing, aerosol drain bag, trach mask, and the oxygen adapter, which would be right here. If the air compressor is running and the heater is warm to touch, but no humidity of the patient, change out the nebulizer bottle, top and bottom. Alright, moving on. Tracheal suctioning. Suctioning is needed when mucus in the airway becomes thick or excessive. Mucus cannot be coughed out by the patient. Some indications. The airflow in and out of the airway is reduced. You hear a loud bubbling or noisy breathing sound. After airway clearance interventions such as postural drainage, using the vest, flutter valve, or acapella valve. Increasing peak pressures on the ventilator or per doctor's order. Some hazards of tracheal suctioning. It is a very invasive procedure, and it has to be done correctly. Hypoxia. If we think about it, we're literally sucking all the oxygen out of our patient's lungs. Tachycardia. It can be an extreme event for the patient being suctioned if not done right, which can elevate their heart rate. Vagal stimulation, resulting in bradycardia, bleeding of the tracheal mucosa. Our equipment and supplies. First thing we're going to need, of course, is a suction machine set at a -80 to a -120 millimeters of mercury, sterile suction catheter and glove kit, sterile water or saline, and we also always must have a resuscitation bag available. Our procedure here, we want to assemble the equipment, turn on the suction machine, wash our hands, use catheter and glove kit, and we want to be as sterile as possible. Determine your sterile hand. I personally, my right hand is my dominant hand, so I utilize my left hand as my sterile hand because I'm going to want to grab everything with my right hand, so I will curl the catheter in my left hand and only use that to touch the catheter. Use your other hand to pour water into a container. Attach the catheter to the suction line, rinse and lubricate the catheter in sterile water. Hyperoxygenate your patient if need be. And the procedure itself here, when we're going to suction, we're going to enter the trach tube. Do not suction on the way in. Enter about 4 to 5 inches until the patient coughs or resistance is felt and pull back slightly. This is very important with the depth that we go down. I'm going to use myself as an anatomy here. As my windpipe goes down, it branches off. This is called the bifurcation. Right at this point is called the carina. And in the carina itself is innervated with a ton of vagal nerves. So if we bring that catheter down too far and slam it into the carina, we can create a vagal response, which will cause the heart rate to drop down to a little less than nothing. So we have to be very, very careful when we are suctioning, not to go down too deep. We want to cover the thumb hole to provide the suction. Slowly remove the catheter, rolling it between your thumb and forefinger to provide intermittent suction. Pull catheter out of the trach tube. 2 to 3 passes is usually sufficient. Each pass should take no longer than 10 to 15 seconds. What I tell all of my nursing staff when we're suctioning is that when you apply suction, you hold your breath. And when you need to take a breath, they need to take a breath because you're sucking all the air out of their lungs. And 10 to 15 seconds is a long time to be down in the resident's lungs suctioning with the catheter. And make sure that we always allow time to let that resident recover. Reapply O2, hyperoxygenate is necessary. Rinse the catheter with sterile water or saline between passes and make note of the color, consistency, and the amount of secretions. And again, this is very, very important. We need to document this. The lung's natural defense system is mucus. And if we document this and we notice changes over a certain amount of periods of time, we can sometimes stop a hospital admission due to pneumonia if we're keeping an eye on the color, consistency, and the amount of secretions that are being produced. Moving on to Trach Care. Perform as policy and or as needed. Once daily, twice daily, or every shift. Or perform as ordered by the doctor. So our supplies, we've got a Trach Care kit, sterile water or hydrogen peroxide water, disposable inner cannula, as appropriate if we're changing out our inner cannula. The skin care procedures. We're going to roll the swab between the trach tube and the skin. We always want to clean from the stoma outward. We do not ever want to get any hydrogen peroxide dripping down into the stoma. Repeat as needed. Rinse the area with clean cotton swabs dipped in sterile water. Pat dry with a sterile gauze pad, replace dressings and the trach sponges. If we take a good look at the trach tube itself, our stoma is going to be resting right here. One place that people forget to clean a lot of times is around this faceplate. There are going to be secretions that are going to crust up there. Very important that we get this clean. If we have to, we'll remove the trach ties, and if you can get an extra set of hands, somebody needs to support the trach tube.